haloperidol-induced hyperventilation as a variant of tardive dyskinesia. So this paper is on respiratory dyskinesia, which is characterized by choreoathetoic movements involving the laryngopharyngeal and respiratory muscles with higher occurrence among elderly females. It can often mimic a diverse array of conditions, frequently leading to misdiagnosis, such as respiratory, cardiac, or psychogenic in nature. Initially regarded as a rare condition associated with prolonged neuroleptic treatment, recent studies have highlighted the prevalence of respiratory abnormalities in patients utilizing antipsychotics. Higashi et al. Study revealed the prevalence of rapid dyskinesia to be 17.5% with the tardive dyskinesia patients. Tardive dyskinesia is estimated to have an annual incidence of 5% in adults and 25% in elderly receiving antipsychotic treatment. These findings underscore the under-recognized nature of rapid dyskinesia or respiratory dyskinesia, as a side effect of chronic neuroleptic administration. We had a 36-year-old Caucasian male patient with history of schizoaffective disorder who was on haloperidol for 1 year. He presented to the emergency department for dyspnea and repetitive mouth twitching persistent for 6 days. Upon physical examination, he had involuntary movements of the tongue, cheek, and lips, and he was hemodynamically stable with a respiratory rate of 36. The chest X-ray and CT angiography showed no acute cardiopulmonary abnormalities, and the arterial blood gas analysis demonstrated a pH of 7.6, carbon dioxide of 13, oxygen level of 126, and bicarbonate of 13. His white blood cell count was 12,000, hemoglobin 19.5, and bicarbonate of 15. So the VMAT inhibitors are the main symptomatic drug therapy for tardive dyskinesia. However, these agents are not widely available. In our hospital, we did not have this medication. Therefore, the patient instead received 1 milligram of alprazolam, followed by 0.5 milligrams of clonazepam, BID, and 1 milligram of benztropine BID. The haloperidol was discontinued and he was switched instead to quetiapine, 25 milligrams daily. Subsequently, the symptoms improved rapidly and he was actually discharged the following day. So while early diagnosis of respiratory dyskinesia is essential, there are currently no established objective assessment methods to diagnose it. Timely identification of rapid dyskinesia would prevent unnecessary testing and the mismanagement and often mistakenly suspicion of cardiorespiratory or psychogenic causes for the respiratory distress. So further research is necessary to establish evidence-based diagnostic criteria and tailored treatment options for this condition. Thank you.
Perfect. Thank you, Sophia. The question would just be, so it seems like this patient was only on haloperidol for 1 year. Was there other differential diagnoses or other risk factors that could be responsible for the respiratory dyskinesia?
Yeah, so we were thinking, maybe he could have anxiety or like a cardiorespiratory cause, and that's like that this condition is usually misdiagnosed or mistaken for those like psychogenic or cardiorespiratory causes. But since right after we switched the medication, it was like an immediate improvement, and the patient was denying any like anxiety, and the imaging and labs didn't indicate like a cardiorespiratory source. Like we decided this is most likely respiratory dyskinesia.
Perfect. Thank you so much, Sophia. Thank you for the amazing presentations.
Thank you.